We're here with Professor Christy Chapin, who is an associate professor of history at University of Maryland, Baltimore County. She's also a visiting scholar at Johns Hopkins. Her professional interests include 20th century U.S. political business and economic history, and she's the author of Ensuring America's Health, the Public Creation of the Corporate Healthcare System, which was published in 2015. Christy, welcome to the External Medicine Podcast. How are you doing today?
I'm doing very well. Thank you for having me.
Excellent. Before we get into our discussion, do you have any financial disclosures?
No, I don't have any.
Excellent. So U.S. healthcare is extremely fragmented, and it's also very, very expensive. In your book, you argue that one of the main reasons why U.S. healthcare is so expensive is the actual model of healthcare, which you term the insurance company model. What exactly is the insurance company model of healthcare?
So I think the best way to explain the insurance company model is first to go back and look at different models, because if not, I'm pretty much just describing the model we have today. And a lot of people will think, an argument I make in my book is we look at the model and the healthcare system today we have today, and people say that it kind of develops, quote, naturally out of markets. It's just naturally what you would find if you have a healthcare sector that's primarily based on the private sector, right? Not being centrally managed, even though we have legislation, of course, for the ACA in 2010. Before that, the way the system developed. So the insurance company model is what we deal with today. And the way you can understand how it is different is by looking back at the first 3 or 4 decades of the 20th century and seeing what the market looked like then. Before, your audience is almost not going to believe this. In 1938, leaders of the American Medical Association, the AMA, actually sat down. I'm imagining it was at headquarters in Chicago, and just made up the insurance company model we use today, which is saying a lot, because that shows that the markets had not produced that model before, because markets tend to merge around solutions that are more efficient, that lessen transaction costs. They don't tend to develop around, an idea that a bunch of physicians in a back room put pen to paper and just invent. And so that's the story I talk about in my book. When in the first 3 or 4 decades of the 20th century, you had a lot of experimentation in the medical market because you didn't have as much regulation, right? It's kind of the wild, wild west of let's see how we're going to organize and arrange healthcare financing, right? And the delivery of services. And you had a lot of different models. This is a period of time where people are now starting to look for insurance so they can pay a set monthly fee, and that way they can balance their household budget as far as healthcare. If healthcare costs are rising because of the discovery of germ theory at the end of the 19th century, medicine is really, it's very prestigious in the United States. It has a lot of cultural standing and value because of all the new breakthroughs and discoveries, and the first time really having these efficacious medicines related to the discovery of germ theory. So for all those reasons, prices were also going up. Hospitals were becoming more modern, surgeries, new technologies, and people were really looking for solutions in the form of insurance, which back then they called voluntary care or voluntary prepayment. That was kind of the synonym. And the models you had back then, you had a lot of different ways of getting your health care. Believe it or not, people think that before the insurance company model developed, well, how do you get health care? People were very clever and they figure out a lot of different things. There were union-run welfare funds, for example, so that when you paid your union dues along with that, there would also be some type of benefit, whether the union decided to contract with a network of physicians, or sometimes they would even manage their own like dispensaries and such that were just for union members and their families. You had consumer co-ops. You had thousands and thousands of fraternal organizations and mutual aid associations in the United States. At the beginning of the 20th century, this is the way immigrants banded together, from one country and pooled their resources in order to buy one another life insurance, sometimes give each other business loans. They act as social organizations, of course, for getting together and speaking the language and eating the food, but also they would provide one another with health insurance, whether it was that they had a physician on hire or they contracted with physicians. So my point is, There were a lot of different models. I'm just hitting a couple. One I'll describe a little bit more in depth because especially for your audience with a lot of medical practitioners, I think will be very interesting and it'll provide a nice contrast to the insurance company model that we use today. And that was the prepaid group model. Sometimes it was called the prepaid physician group model or something along those lines, prepaid doctor groups. And under this model, what you had physicians doing, this is so interesting, is practicing as groups, which I know you do today, but in this case, they were multi-specialty. So for the patient, it was a great way for them to have, as we would say, one-stop shopping. So if you're oncologist and surgeon and, orthopedist and pediatrician and GP, as you imagine, if they're all under one roof, that's the very different way of practicing medicine. It's not fragmented, it's integrated. And that made a very big difference too in the way physicians practice medicine because they were practicing together really across specialty in a way that they do in hospitals, but still not in the way they did under this model, where at the end of the day, they would sit down and talk about the difficult cases or the cases where their patient had more than one illness or it was tricky or they couldn't figure out what the condition was. So I think it was a more creative way of practicing medicine because you're learning a lot more cross specialty. And so I think there's a lot more for the art, not just the science of medicine there. So that was one thing that was unusual, these multi-specialty practices. The other thing that was unusual compared to today is the physician groups acted as the insurer. So you have the physician acting as the insurer. Families and individuals would pay, just like we do today, a monthly payment, but instead of it going to an insurance company, it would go to the actual prepaid physician group. And this was very important for holding costs down while also providing high quality care. And I want to emphasize this point because if you look at all the healthcare systems around the world, one thing you'll notice is they all suffer from one of two things. And it might depend on what kind of patient you are in each system. They might have both problems. And that is one, the rationing of care. And then the other one is the overutilization of care, excessive, utilization, where there's providers are somehow incentivized to provide too much care. Again, that could be for certain patients and not others. But the great thing about this financing model with these prepaid physician groups was that because physicians were tied to the bottom line, basically the way most doctors were paid was they had a salary. So it would depend how junior you were in the organization, but you would also get a cut of the quarterly or biannual profits. So you really were tied to the bottom line. So obviously, if you're just needlessly, excessively offering services and tests and labs, because a lot of these prepaid groups were so big that they even could have their own ambulatory surgery, facilities and labs and all types of other facilities that they aren't by law usually in a lot of states allowed to do today. So they were not incentivized under this model then to over provide care, because if they're just excessively overutilizing services, that's coming out of the physician's back pocket. On the other hand, they're also not incentivized, or they were not incentivized to ration care, because if patients were unhappy with the care they were receiving, the word gets around. And also when you kind of own a patient the way these groups did, you're providing comprehensive care to them in one place. You can't just, go through the test and say sorry and send them on to the next specialist. I mean, you really own the health of that patient and how well they do. So it's in your best interest to use preventative medicine. It's in your best interest to have nutrition classes for your diabetic patients, because that's just smart finding. I mean, it's great for their health, but it's also going to really show up again in your back pocket in the way that you're paid. And my argument is that because of the amount of expertise they have and the amount of education they need to have, it makes sense to incentivize physicians of all people to walk that line between over provision of care and under provision of care, which instead right now we have the insurance companies walking that line, or other systems. They might have healthcare officials and government officials trying to figure out where that line is and how to do it. And it's very difficult because it's difficult for them to be in the room and have the same expertise that physicians and other medical practitioners do.
So how popular were these prepaid physician groups and also all of these other models at the beginning of the 20th, end of the 19th centuries?
Well, that's a great question. There were surprisingly lots of them. I mean, thousands and thousands of these different groups. If you're looking at the different models, the prepaid doctor groups, I estimate there were a minimum of 500, but probably a lot more in the country during the early 1930s. In fact, a lot of them were also copied during the Great Depression when you have agricultural officials experimenting in healthcare with farmers associations and such. But so they were very popular. Same with union welfare funds, same with mutual aid societies and the benefits they also provided. I mean, you had one African-American mutual aid society that was so big in the South that they built their own hospital. So all of these different types were very popular. The prepaid physician groups, I believe, would have been the dominant model if the market had just been allowed to, develop as it wanted to develop without being imposed upon by outside forces, because they were wildly popular with consumers. They were also kind of a pet cause of a lot of progressive people who had a lot of progressive ideology. They were hoping to build the market around these prepaid physician groups so that which they wanted the government to get involved in the medical sector, it would already be arranged deficiency, and that it would be easier for a federal government to come in and then inject some measure of regulation and payment, especially in a country as big as the United States. As you can imagine, why they were thinking in the 1920s and 30s about having the private sector organized a certain way before the government intervened. Even by the time we get to Truman's bill at the end of the 1940s, his proposal for universal health care, you have still a lot of reformers left over from this more progressive era period, 20s and 30s, who were trying to build that system. They would have allowed Blue Cross and Blue Shield to stay because they were nonprofit, but they were mostly trying to put the system back on the prepaid group model because they recognized the efficiencies of it. They recognized how it kept costs down. And this is one thing progressives were all into, was efficiency, having the experts figure out the right ways to do things. And so they did a lot of surveys around this, and they there was a lot of great publicity around the prepaid physician groups. They were able to offer so many more benefits than any type of insurance company plan. You have them providing benefits in the 30s that insurers weren't able to figure out how to provide without just going completely bankrupt until like the end of the 1950s. But that's another story in of itself. But it's because they were able to keep costs down that when you had a plan with them, you really did have comprehensive, great, generous benefits that you don't see when the insurance company model is getting off the ground in the late 30s and the 1940s.
So we want to talk about some of the major players in the formation of American healthcare. The AMA, of course, Blue Cross Blue Shield, and HIAA. But really quickly, just for people who listen to that description of prepaid physician groups and say, that sounds a lot like Kaiser Permanente and HMO. What exactly is the difference between the prepaid physician groups and something like Kaiser?
Well, Kaiser is still very third-party financed and driven, where the prepaid physician groups were started, managed, owned, and arranged by physicians themselves. So with Kaiser, for example, if you look at the way physicians are paid, you'll immediately see how then the incentives can get out of whack from what I'm talking about. They try to keep costs down because they have a third party giving them certain directives, just like a lot of physicians who practice with insurers do today, whether it's a standardized treatment blueprint or something along those lines. Kaiser just has even more dictates. Unfortunately, a lot of the physicians even get bonuses and stuff from withholding care, rationing care. But you have it really coming down from outside, like a business, a third party, because Kaiser was originally, of course, a builder or a shipbuilder, and he ended up contracting with a physicians group, but it's third party in the sense that the physicians themselves are not in charge. And also because of the model, the way they built it up and scaled it, you don't really have physicians practicing together. Okay, they're all together in a building, in separate departments. That's still not the same thing where you have like somebody walking into their general practitioner's office today, but instead it's a multi-physician practice that takes care of your whole family. But then, of course, if you need to go to the hospital, that's, something separate. So yes, Kaiser is still very much third-party directed. And so patients often the biggest complaint you hear with Kaiser is rationing of care. And then physicians too feeling that difficulty of working under a third party, in this case, a business, but you can look back at other models and see, oh, you could have worked for a union, right? So, and this was something the AMA, the American Medical Association, was very worried about. They did not want physicians working for certainly not for lay people, businesses and unions. they didn't want physicians working for other physicians to either, that's one of the things that gets them in trouble with their refusal to deal with any of these models. They don't want to have anything. And again, I only hit on 3 or 4 different ones and talked a lot about the prepaid group model. And I know we still haven't gotten to the insurance company model, and we will. But the kind of, I'm sure the audience at this point is saying, well, what happened to all these models? And the punchline of that story is that the American Medical Association, as famous as they are for opposing government intervention in medicine, again, something your audience is probably very familiar with, they were also very opposed to anything that was market-based, free market competition, doctors competing against one another. They were very fearful that corporations were going to take over the medical field. Makes a lot of sense at that time. This is the period in the 19th century, right? You have the rise of large corporation. They don't want physicians captured by the large corporation like the engineers are, right? So this is something they're very concerned about. And they look at prepaid physician groups and they say, well, you have capital pooling, you have prepayment, you have physicians working together that could, looks like a multi-divisional corporation. So that is one reason that they were so opposed to even the prepaid physician groups, along with, so they were proved, the AMA at this time was against both group practice because it made them nervous about corporate organization, and they were against insurance. They were against any kind of prepayment, voluntary prepayment policy, whether it was through the mutual aid association, fraternal order, union, business, whatever it might be, because you have that pooling of capital, plus you have the introduction of a third party that might come in and start to be in some kind of supervisory position over the physicians. So that is why they opposed all of these models. And at the time, the AMA was far more powerful than it is today. I know it's still very powerful, but then it was very, very powerful because they pretty much owned every single state licensing board. So if you cross the American Medical Association, not because you did something wrong in your medical practice, practicing medicine, but if they don't like your political beliefs or, the color of your skin, or if you're a woman, that's a whole nother problem too. But they don't like what you're doing in the marketplace. They don't like that you're contracted with the Irish Mutual Aid Association or the Jewish Mutual Aid Association or whatever it may be. Very easy for them to pull a physician's license because those were all pretty much AMA loyal doctors running those boards at the time. It's not that way anymore. And also they had such a lock over hospitals, again, very hard to believe today, that it was very easy for them to get a physician's admitting privileges revoked if they caused any problems. Certainly, if you're a specialist, there go all your referrals from anybody involved in the medical society. Your audience should be aware of the fact that AMA, one thing that made them so powerful is they were nationally headquartered in Chicago, but every state has an association. And then because every county and city, or most counties of any size and cities also had them, you can see how AMA had eyes in every single, corner of the United States. You couldn't get away from them, even back in the 1930s. And that gave them a lot of political power too, because they could lobby at every level of government. So they have all those models shut down before we get to the insurance company model. And I've been talking for a while. I know we got to get to that, but I feel like I should stop and let somebody else say something.
So when I think of the AMA, I think of the daily email they send me to watch out for burnout, or begging me to listen to their podcast, which I never have. But, it was a very different organization, as you describe, at the end of the 19th, early 20th century. I was wondering, could you describe the founding of it and how it sort of evolved to be in the position it was at the end of the 30s when it actually decided on the insurance company model?
Sure. So with the discovery of germ theory at the end of the 19th century, that brings a lot of attention, as I was saying before, to medicine. And if you haven't noticed, our culture is very enamored of science and medicine. We're a culture that very much celebrates that, right? So this was good for the professionalization of physicians in the United States. I mean, at the end of the 19th, the beginning of the 20th century, medical discoveries and scientists, they were the Kardashians of today. They were rock stars. All this was, always reported breathlessly in the newspapers at the time. People were very excited about all the new, efficacious medicines that were coming online. I mean, think about something like, the diphtheria antitoxin, which we get at the end of the 19th century. That's a disease that just killed so many children. You think, you'd have these families 11 kids, comes to town, 8 die within 2 weeks. And, this is just something we in the West can't imagine today. So this is explaining why science and medicine is beginning to have so much more cultural authority than it did before the discovery of germ theory, when we were still going off of concepts that really stretch back to ancient Greece and Rome, Galen interpreting a lot of Hippocrates, balancing the humors, bloodletting, all the great stuff we know from the history of medicine. But with the discovery of germ theory, that's really making people start to think about physicians differently. And the AMA, founded in 1847, you have a lot of state physician associations already existed. They come together, have a national convention, create the National Society. And what they do is they capitalize on the momentum we get at the end of the 19th century with all these medical discoveries and a lot of excitement in the press to get states to pass and strengthen their medical licensing laws, which becomes a very important way for the AMA to regulate the medical economy. Right. So we think about them with medicine and standards with that, but it's important to see how at this period, again, they don't have that power now, how much control they had over the way the healthcare market developed. So they used their power to do that. They also used a lot of their power and cultural authority to get a lot of medical school reforms, which was an important thing of bringing the United States being looked at as a top place to go and study medicine before the 1880s, really even 1880s before, you wanted to go to a European medical school. You didn't want to go to a school in the United States because these were all backwater, really just made fun of institutions. I mean, you have jokes at Harvard of being like, well, if you're too stupid for classics or amoral to study religion or, for the pulpit, then you can go to medical school. I mean, so it really takes Johns Hopkins coming along in the 1890s, having that European model of both research, the hospital attached to it. That's the model that all the other medical schools are going to follow once you have a lot of reforms occurring at the beginning of the 20th century. So these are all important.
But the Flexner report is what you're referring to.
Exactly. The Flexner report, again, that's probably something that's so common that even a lot of your audience members know about that piece of medical history and how important that is for physician professionalization. And physicians presenting them. And so you see they're gathering this economic authority and power, this political authority and power socially. Of course, this is great too, that the physicians in every town and every association are going to be, at the same country club with the mayor or the governor or the state senator, and again, at every level. So the AMA is very wisely capitalizing off of all of that so that the United States goes from this backwater where you don't want to get your medical degree, so that by the beginning of the 20th century, you're already seeing that JAMA, the Journal of the American Medical Association, is probably the top medical journal in the world. Or at least one of them, which is also interesting because the whole time they're also sending out these inflammatory editorials about whether it's government healthcare reform, but also threatening physicians. I have to laugh about this because I'm laughing about one I'm remembering, what they're just saying, we will come after you if we find that you contract with one of these union welfare funds or mutual aid societies or get involved with a prepaid physician group, we will come after you and get your license from you. So it's all there, what they did and how interested they were in these topics. So that gives you an idea of the power. And so if you see how these even local medical societies were so powerful, again, not like they are today, they do not have the reach. We don't have, the AMA reaches its peak of membership. I'm not even remember the numbers. I think it's close to 80% in the early 50s, which is really good because a lot of retired physicians and medical students weren't going to be, affiliates anyway. But it was because of the overwhelming benefits of being part of the quote unquote, the good old boys club, because you don't want them coming against you. They will get mad if you don't follow along with the norms of the physicians of that town do, and whether or not they're going to decide that they want another Black doctor to come to town. That's going to depend on how they feel about their economic position, if they want to take more Black patients or not, or what the fees are going to be. And you better not try to undercut them. Like that's something that'll make you lose your medical society membership. Again, your hospital admitting privileges could threaten your license. Like anything you do to make the established powers that be could cause a lot of problems for you if you are a physician in a way that it just can't, that it doesn't today. I mean, I know physicians get disciplined before medical boards if they do something medically, malpractice or neglectful, but not with all these other ideologies, skin color, gender, and all these other issues.
One thing that was very interesting in reading your book and seeing quotes from physicians, people who were high up in the AMA, supporters of the American Medical Association, writing in the 20s that we really don't want any interference. We don't want to put anybody above physicians in the practice of medicine, because ultimately this will lead to physician's role becoming that of, as you said earlier, an engineer controlled by somebody else. So, we sort of have these two different trends here. You mentioned in 1938, the AMA supported in the insurance company model, but prior to 1938, the AMA was vocally opposed to anything aside from this romanticized 19th century physician as solo practitioner being directly paid by their patients. What exactly changed?
Yeah, so that's a great question. So we have the AMA out there stamping down anything that the market comes up with, right? So then all of a sudden, 1938, they changed their position on health insurance and decide it's okay. A few years earlier than that, they say it's okay for poor people because it's the middle of the Great Depression, right? But now they're going to give their full stamp of approval to health insurance for everybody. 1938, and the reason is because simply the political pressure that they're under. This is the Great Depression. This is during the New Deal period. You have all these unprecedented expressions of federal power in various economic sectors. It makes perfect sense that reformers are going to be looking at the healthcare sector, especially when the AMA is busily destroying it the best it possibly can, right? So the AMA is bringing a lot of this political pressure on itself because it's making the issue very low hanging fruit for political and ideological progressives and reformers who want to get more involved in various economic sectors. So with all that political pressure, like when we had the 1935 Social Security bill go through, that's really kind of like the foundation of the American welfare state. We get, of course, the Social Security system, unemployment benefits and such. And a lot of the people on the committee who create that legislation want to put in funding for healthcare, medical benefits. But President Roosevelt realizes it'll sink the whole bill. Again, understanding the power of the AMA and what they can do. Very savvy politician. But then he holds, he creates a technical committee on healthcare. He holds a big fancy national conference. There's all these things that are making it clear that people are very interested in getting the federal government involved in healthcare. You finally, at the end of the 30s, have Senator Wagner offering legislation at that time just to send federal funds to states to create their own types of medical care programs. So the AMA is realizing it can't fight this massive two-war battle, right? It can't fight everything with the government trying to get involved in healthcare and try to shut down every single thing that consumers and physicians and patients and that everybody else seems to want to happen but the AMA. So because of that, the AMA says, all right, okay, we're gonna approve what they called voluntary prepayment. Again, that's just a synonym for insurance. We're going to improve health insurance. We're going to say that you can have it. But what they decide to do, it's a very explicit strategy, and they talk about it all the time. They create this market, this economic model, and then they hold it up and say, this is the voluntary market. Today, we'd probably use the term free market, right? They would say voluntary market. That was the rhetoric they used. This is the voluntary market model. And they hold this up against any type of government intervention. Of course, not telling everybody that they killed every other truly voluntary market model. And the model that they create, again, 1938, physicians, back room, Chicago, of course, they're all white males, right? Is that only insurance companies can be involved in prepayment, because having a mutual aid society or a business like Kaiser or shipbuilder or whatever business, or a consumer cooperative or a farmers association or a prepaid group model, that puts super supervision over the physician geographically. It's very tight knit. But if you're just dealing with insurance companies that are headquartered in one city somewhere and you have physicians all across the country, well, at least you can keep them as far out of the picture and as far out of the exam room as possible. So they decide they're going to say okay to health insurance, but only through that mechanism. They also, this is where the insistence is laid down for fee for service payment, which is something that leads to overutilization because, as your audience knows, you bill for every single procedure and service. Insurance companies were not allowed to pay salaries like Kaiser. Kaiser is an alternative model that the AMA hated and fought against, but they just, some of these models slip by if they have enough political protection. Right. Sometimes if there's a consumer cooperative allied with farmers and a certain, like in Iowa, right, they're going to have a little more political protection. But as I was saying, so they don't want any third-party prepayment insurance through anything else, only insurance companies. So that's goodbye prepaid doctor groups, have to be paid fee for service, no salary payment, no capitation, which is just a fee per patient, on a quarterly, biannual, annual basis. And even initially, believe it or not, physicians just set whatever the fee was that they charged. Those fees actually get standardized more and regulated more starting in the 50s. But at first, they just, shocking, every place insurance came in, the fees jumped high, obviously, because the market could bear it, because you have a third party paying for services and they're way far away, right? And so the insurer can't even, they don't even know how much of the service that they're financing is going to be supplied. And they're not allowed to ask any questions about it or have any supervisory power at that time, regulatory power over physicians. Obviously, that's going to really change. That's really going to start to change like a little bit in the 50s. And then it's just going to really start to incrementally build so much once we get into the 70s and 80s and 90s to where we have today, where I've said the dynamic and power is really flipped. Whereas instead of the physicians in charge, you have the insurers really at the center of everything and far more in charge, which was the AMA's leaders' nightmare when they sat down in 1938 to create this model that paradoxically, ironically, all the words you want to use, created the very thing that they were trying to avoid. So that's that 1938 model. Insurance, only insurance companies, fee for service, no group. They ended up letting single specialty groups slide, but certainly no multi-practice group. That looks a little bit too like multi-divisional, like a corporation. So they went after and did have a lot of prepaid groups shut down. And of course, the message was, don't try any of these alternative forms. That's what they called them, alternative. Actually, the insurance company model's the alternative because it was, it came up with post hoc. So it's an ad hoc way of approaching it. So after they come up with this model, they're getting rid of all the others. Quickly, insurance companies are signing up employee groups. You had already had some demand from a lot of corporations that wanted to ease union power, for example. They wanted to avoid that, or at least take some of the power away from the union. So you have a lot of corporations immediately starting to contract with insurance companies in order to get these health insurance benefits from them, because they already had standing relations with them, because they already sold them group life insurance policy. So then just offering the medical and health that made a lot of sense. But the insurance companies were not happy about getting involved with this. You have to understand, when the AMA comes up with this model and says, this is the model we're laying down, everybody at the time recognized it was going to create massive issues. It wasn't a secret, and it wasn't even an ideological issue. Yeah, I often point out it was like, conservatives and progressives and right and left and Republican and Democrat and insurers and physicians, everybody could look at the model and see why it was going to cause cost issues, because there's no mechanism to balance out the number of services, that are provided. The incentives just aren't set up right. So that's how that all gets started.
So let's introduce a couple of the other characters in this story. You mentioned physician reimbursement, which makes me think of Blue Shield. And I always thought that Blue Cross Blue Shield was one organization, but as I learned from your book, that in fact, no, there are two separate organizations that often butted heads, both with each other and also with the American Medical Association. So what exactly is Blue Cross? What is Blue Shield? And where do these organizations come from?
Well, Blue Cross started in 1929 when you had hospitals starting, because again, this was a period of experimentation and financing. And what you had hospitals realizing is, why don't we just offer our own insurance, just like doctors did with their own groups, right? Where they acted as the insurer. Basically, you had hospitals doing the same thing. Hey, families, individuals, why don't you just prepay us a certain amount every month, and you have you have on hand, you can access your hospital benefits. And they would also work with like unions a lot of times, for example, in order to make collections and administration efficient. So you have Blue Cross starting, you have one hospital beginning this, down in Texas in 1929, but as this model starts to spread across the United States, you have the American Hospital Association wanting to get out ahead of it and lay down some rules, which they do pretty quickly. For example, one thing they want is, if there's going to be this Blue Cross, they want all the hospitals in one area to be in the same prepayment plan. They don't want every hospital having a different prepayment plan. And so that pretty quickly happens in the early 30s. And with the American Hospital Association getting very involved with it, because there's so much demand for this prepayment and health insurance, Blue Cross spreads very quickly. It spreads, and it's every state, ends up with one. Some states have more than one. They do compete against one another. Believe it or not, they are separate companies. And the thing that makes Blue Cross and Blue Shield different, and during this period, is they were all nonprofit. Today, some are, some aren't. But I would argue even the ones that call themselves nonprofit pretty much behave like a commercial or for-profit insurance company does. They lose a lot of their differences by the time we get to the end of the 1950s because of the pressures of the market. Like, for example, community rating, where they prided themselves on community rating, where they would offer for each tier of a market, everybody paid the same price, right? That's what community rating was. Whereas, then commercial insurers, it was more experience rating. Are you a relatively healthy employee or, employee group? And then each individual employee is going to pay a lot less than somebody buying in the individual market, where adverse selection is more at work there. The types of people who are most likely to need insurance are probably going to buy it in the individual market and seek it out. And you have all the, the information problems that make it difficult for insurers. So I think I'm kind of losing the thread of where I had started, but this is what's going on with the development of Blue Cross, that they're an insurance company, but because they're a nonprofit, they are trying to do some of these things like community rating, right? To say, we have these nonprofit values, right? We're not just here for the profit. And because of that, they enjoy a lot of favor in contract negotiations with unions. Unions often want them to be their provider because there's that, the ideology around using a nonprofit, although the unions get really mad with them around the 50s, where they start behaving more like commercials. So that's how Blue Cross really starts to grow and take off. And then commercial insurance, they're still going to contract with the hospitals, but they don't have as tight a financial or regulatory, any types of such tight relationships as does Blue Cross. Blue Shield, very oddly enough, is started by AMA medical societies. And the National AMA organization is pretty mad about this, but they kind of have to let it go because they'd already approved this model, but the insurance company model in 38, but they were kind of dragging their feet on it. They still weren't very happy about the idea of offering insurance. But Blue Cross, as it grows, they naturally also want to offer insurance for physician services. And of course, the AMA medical societies are like, don't you even think about it, right? Or we will, So instead, the medical society, and then Blue Cross is even looking at joining with for-profit insurers to cover physicians. So that's why the AMA medical societies are like, fine, we'll start our own Blue Shield. So they're run as separate organizations. It's very hilariously inefficient. And they're the kinds of battles that go on between Blue Cross and Blue Shield in certain areas, between Blue Cross and the physicians, between Blue Shield and the physicians, Blue Cross and the hospitals, and all these different areas. It's very complex, and it's they don't grow along smoothly and all because there's so much bickering with the providers that they're insuring at this time, when physicians still have a lot of power. So that's where you get Blue Cross Blue Shield. Blue Shield comes online. I say Blue Cross, it's spreading all throughout the 30s. You don't get Blue Shields being founded until really the mid to late 40s. And that's when you start seeing all the Blue Shields come on. Some areas they end up joining boards together. Some areas they work on completely different boards. It just really depends on the area.
And Blue Shield, although it was originally founded by the AMA, at certain points aligned itself more with Blue Cross and was actually fighting with the AMA in order to try to, I don't know if it was specifically to reduce the power of physicians, but because their interests more aligned with them later on.
Yeah, and even politically too. Think about it. Hospitals have long been more favorable towards the idea of government intervention in medicine for kind of obvious reasons. They were long funded historically through charitable contributions, contributions through the municipal government, or the local community chest, local businesses. They're used to taking these sources of funding from different places, often governments, and so they don't see the big problem with the government getting involved in healthcare the way individual physicians who are trying to think about their professionalization and where they want that profession to go are going to think about it. So in political battles in the 40s and 50s, I mean, Blue Cross and AHA are certainly against the Truman's universal healthcare plan, just like every other private interest is. But by the time you get to Medicare, for example, Blue Cross really is in favor of Medicare, as are even a lot of for-profit insurance companies at that point, because they're sick of trying to cover trying to cover senior citizens, and they're barely giving them any benefits, and still they're losing so much money. But then Blue Shield's supposed to stay in line with the AMA, and they just find it really hard to do around the Medicare battles. The AMA has a hard time keeping their rank and file, very hard time in line for the Medicare battles, not with Truman battles, but by the time we get to Medicare, that's really the point you can see a big switch and a decline in the AMA's authority and political power after that. So that's where Blue Cross and Blue Shield, they're so much closer to the providers historically. And that's why you see these different relationships today than are the for-profits of the commercial insurance providers. So for example, even when Medicare is created and you had the insurance companies pretty much administering the program, that's why Blue Cross and Blue Shield are often chosen by the providers in each area to be the representative, if it wasn't like, Aetna or whatever other for-profit might be chosen. And then, of course, you have the for-profit commercial insurers, which, they might have been in property and casualty insurance, life insurance, but other kind of insurance. And then they began offering a health insurance line in the late 30s to early 40s. But again, I do want to go back and say how the insurers were not happy about offering insurance under the AMA's insurance company model. And so your audience is probably wondering why. Really quickly, they had been getting a lot of pressure from their corporate clients, but I'm laughing because I was in the archives and I would see them like Equitable say, no, we are not offering you health insurance. We're going to lose our shirts on it. But they decide to join with the AMA to keep the government out of healthcare. This becomes a really big issue, especially following World War II, because there's this idea, World War II, a lot of politicians are looking at how are we going to recreate the economy coming out of World War II, right? Because before that, a lot of people think we're going to go right back into the like conditions were in the Great Depression in the 30s. And so there's this feeling like, are we going to go more like Europe with a larger welfare state and more government intervention in the economy and control, more nationalized, like say transportation and energy companies and stuff? Or are we going to be more the American model that we know today, which doesn't have as heavy as a government footprint, although I would kind of argue about that, but still. And insurers really thought they were kind of taking one for the team as far as the entire business community. The idea was if we can keep the government out of healthcare, it was like the domino theory. If healthcare falls, every sector is going to fall afterwards. So we're going to step up and take one for the team by keeping the government out of healthcare, even though we are not at all happy about getting involved with financing services that we can't see, control, don't know anything about, can't even forecast the number that is needed. So
that's a perfect lead in to our next question. So you mentioned Truman's proposed healthcare plan, nationalizing healthcare in 1948. Can you describe what that legislation was and how the AMA went about defeating it? Something you say was the, quote, largest political offensive ever waged against a single piece of legislation in U.S. history.
Yes, it very, very likely was. So you had a bunch of, we already talked about how during the 30s, there's all this talk and chatter and conferences and, important committees looking at the healthcare problem. And then you have legislation starting to come out. You have it even in the early 40s. And of course, looking what's going on over in Europe. But when it really starts to gain steam when Truman surprises everybody and actually wins the 1948 election. And one of the things he campaigned heavily on was this idea of universal health care, kind of carrying forward a lot of points of the New Deal that with his Fair Deal. And the argument that reformers, a lot of people in the Social Security Administration at this time were pushing this. And also you would have union leaders working very closely with them on this type of legislation. They were pushing for a universal healthcare system. And like I said before, they really wanted to get back to more the prepaid group model and Blue Cross Blue Shield, or at the time there were more Blue Crosses, and having patients use those facilities, but having the government provide it for everyone. But because the arguments so much revolved around, hey, for less cost than people, pay now for a private market policy, we can provide more generous benefits, provide it for everybody, and do it more efficiently because will have centralized bureaucracy running it. And that was the argument. Well, of course, you have the Cold War going on. So, if you can label something socialism or communism, that's going to help politically, which is what the AMA is going to do with their allies, who are everybody from the American Hospital Association to the Chamber of Commerce, National Association of Manufacturers, all the business groups, all the insurance groups. We're going to give the HIA, the Health Insurance Association of America. Today, your audience probably knows them as AHIP. I think it's America's Health Insurance Plans. They had a big hand in like the 1990s Clinton healthcare defeat. They're also very much involved in this. They launched this big promotional propaganda campaign against the Truman Plan. And their whole argument is this is the voluntary sector's answer to the socialistic communistic plot. Now, again, we know the backstory, knowing that this is not the markets. This is not at all. This is a few guys in a back room in Chicago, right? But that's what the whole campaign is going to turn around, is this kind of Cold War framing of, free enterprise and free markets, which again, the AMA leaders hate. They would probably almost rather be taken over at this point by the government than have to think of themselves as competitors in the crass commercial markets, like a mere peddler, right? That's very offensive to their professional ideals. So, that's the way the AMA is going to present it. And so they have billboards and radio ads. They have posters in physicians' offices. They have pamphlets out. You had physicians writing prescriptions for which senator to vote for, who would vote against the Truman Plan, which wouldn't have just been Republicans. It would have also been conservative Democrats and Democrats from the South. That doesn't mean they didn't want to reform healthcare, though. A lot of people who voted against Truman's plan in the Senate and the House still wanted a reform of some type, which we'll talk about in a second. But because everything is set up, like which is better, the private market plan or the government market plan, this forces physicians and insurers to really run, like kind of to ally more than they want to, right? Because the physicians are looking at the insurers, they're not happy about having to accept insurance, certainly the leaders. And it's really out of their hands. It's a third party. And the insurance companies didn't really want to get involved in this. They just had to for political reasons. But the Truman debate is really forcing them to ally and be like, we have got to build this insurance company model up quickly, because if we can build it up fast enough and showing that it's growing quickly enough, they won't have a reason, an argument to make for the government to get involved. Look what a great job we're doing. Look how fast we're growing our coverage. And so that's what you see them doing constantly, saying like, look how many thousands of people we added to the insurance rolls last year. You see them showing up all the time. Look at how much more generous our policies are now, because the commercial insurers and even Blue Cross and Blue Shields, they cannot offer the benefits that some of those earlier models that had ways to control their costs could. They could not do that. So their policies were far more stripped down. And then you had so many problems with every year, the price like jumping up by double digits. So much the price increases because they're under this insurance company model. And the prices just keep shooting up as was predicted. But through this promotional campaign, they're able to make the case to the American people overwhelmingly of, oh, the market's got it taken care of. We're America, mom, apple pie. We don't do communism, socialism. This makes sense. There's a famous painting that was turned into a poster that has, I can't remember if it's 19th century painting, but it's a physician tending to a young patient in his living room. You know, back in the day when you did house calls, they still did that in the 40s and starts to go away in the 50s. And it says, keep government out of this picture. So you can see why the way the terms of debate were set up, Truman's plan failed. But even though it failed, because it was like, oh, that's universal, it's centrally managed through DC, that's not a very kind of American type solution. Because again, the cost problems, the more limited benefits, the fact that even though they were growing health insurance as quickly as they could, organize doctors and organize insurance companies, they obviously weren't covering everybody. Because of that, even after Truman's plan is defeated, and by the early 50s, it's clear it's not going to pass. Once Eisenhower's in office in 52, you have Eisenhower and Democrats and Republicans in the Senate and House all coming together and repeatedly offering different programs. Some get more steam than others. One of them actually looks a lot like the ACA, state exchanges and then subsidies. And it was just sometimes whether it's provided from the federal government or the state. But everybody recognized at the time, even if they didn't want Truman's centrally managed, through DC universal program, that still this model somehow needed to be reformed. So
one of the other major contributors to how U.S. healthcare is currently, the employer-sponsored healthcare model, came out of the early 50s when the IRS made it so that companies could use pre-tax dollars to fund employee health coverage, effectively a tax write-off for tons of companies. How did that decision actually impact the development of health insurance?
That's a good question, because I bet that a lot of your audience members know, as far as, thinking of stylized facts of healthcare history, a lot of people look back to World War II and say, because of the price or the wage caps that were put in to fight against inflation, that a lot of businesses began offering employer-provided healthcare. Right. And we already talked about how these relationships were set up, because a lot of them were already providing life insurance benefits. Now they could offer health insurance benefits and compete for scarce labor by using benefits, since they couldn't increase wages. Although that story has been told a lot, and it is true. If you look, you can see the kind of insurance company benefits ticking up through World War II. The truth is that there isn't an unusual tick up. It's just the actual incline you would expect to see. It goes back to when the IRS was founded in 1914. It gets its constitutional amendment in 1913, but they have a loophole saying that if businesses are spending money on employee fringe benefits, that can be a tax write-off. And this becomes a very valuable tax write-off when they're trying to fight unions, right? Unionization, that, hey, workers, if we're providing you life insurance and pension plans and health insurance and all these benefits, why do you really need a union? Or if they do have a union, then the union starts to bargain over these different fringe benefits. It becomes a key role of unions in the United States. So I think I'm losing my train of thought. What was the question again? I'm sorry that I'm going off on a path and can't remember what I was talking about.
The role of employer-sponsored health coverage made possible with pre-tax contributions, essentially a tax benefit to companies in contributing to our current healthcare insurance-based model.
Right. So if you look at the numbers, it's really just the fact that the IRS had this loophole. And as soon as the physicians decide on this insurance company model and the green light kind of goes out, as I was saying, you immediately have insurers working with their corporate clients that they already had to provide pension and life insurance benefits. And then, of course, it grows as you would expect through World War II, but it just keeps growing because physicians and insurers are trying to spread health insurance for political reasons. That's the main reason insurance is growing so rapidly. It's not even that insurers necessarily want to keep trying to to sell this product, especially, not outside of the employee group market, again, relatively healthy individuals compared to the rest of the population, but it's a political project. And that's what is really pushing things with the employer getting the write-off. It gets institutionalized in the tax code in, I think it's 1954, because you have a lot of officials saying we are foregoing millions of dollars of revenue because this is a really nice tax write-off. But once it gets institutionalized, and for the very reason of Republicans and conservative Democrats want to help insurers quickly grow coverage in the voluntary or private or free market, in order to keep government, very robust reform programs, in order to be an obstacle to those. So that is why today you buy. And I just wanted to say one more thing, though, to just how much it really messes up. I think we're all used to getting our insurance for an employer, but the fact that you don't have a choice, or if you're very lucky, you can only choose from 2 or 3. Again, just think about that logic with, say, a car market. I know some people have company cars, but still, can you imagine how much more limited and odd the car market would be if we all expected that that's where we're going to get our car, and you can't pick the color or how many cup holders of the CD or the GPS or all those other things that are important to us. And so you can imagine how then that just interacts with the insurance company market. And again, is concentrating power in odd places, with CEOs and executives and owners of businesses, and not with the patient who has the protection and the physician. This stuff is being outsourced to big corporations. So
and it's strangely a subsidy for middle-class Americans at the expense of people who work for themselves and are business owners, or the people who are poorer and aren't able to get anything through their insurers. And of course, I mean, people that don't have jobs. But of course, that was developed. Another type of insurance was developed for them later on. I know that we're sort of in the 50s, almost getting towards the 60s with Medicare and Medicaid's passage.
Yeah. And also, even to go back to the comment you made, what's so interesting is, even though there is a robust individual market, actually in the 50s, because of this political project of hurry up and get as many bodies on the rolls as possible, the individual market's far more robust than a lot of people realize. It was like 30% of the policies they sold were on the individual market. And again, they didn't want to do that. They didn't want those customers. They were too risky. But it was a political reasons. Right before ACA passed, that market was about 10. And it was a lot of people who worked for themselves, or, had, as you were mentioning, people work certain jobs where they don't have fringe benefits, or maybe part-time or whatever. But the thing that made the individual market so much worse than it would have otherwise been was that they picked this super special model that was going to drive up costs. Like, if it had been a prepaid group model, whether or not government had intervened, you could imagine, even if you're not getting the benefit through your employer, where you can just go out and, just like we go out and buy our cars, it's still a big cost, but it's not this impossible thing because some odd model that somebody invented in the late 1930s has caused the cost to be 5 or 6 times higher than what we're used to today. So that's just another thing to think about, why the kind of problem it becomes where people get caught by Medicaid. But if you have that, what we often call the working poor, or people who aren't up to the fringe benefits, working in the service industry or something, why it's such a big problem for them, because insurance is too expensive to be bought. And then employees who are getting it through their employer think, well, I just pay $100, a month for me and my family. And you're like, you're foregoing $40,000 of pay, but you don't know that, you don't see it. You just think that you're getting, it's not that big a deal. You don't see it, so you don't know. So those are the kinds of distortions that are happening that people, it's hard. You got to kind of sit there and look at the big picture and think through the whole why the individual market is so bad for people and why there was so much room for reform. But I am now messing up your chronology. You're trying desperately to get us out of the 50s into the 60s with Medicare and Medicaid.
Yeah, let's go to the 60s. So in the 60s, Medicare gets passed, and you argue that with the passage of Medicare, afterwards, it's pretty much impossible to dislodge the insurance company model from healthcare. Can you elaborate on why you believe that's the case?
Yeah, basically the very strategy that insurance companies, the AMA, came up with, and I'm not just reading this into the documents, they are so explicit about it. I mean, it's almost impossible in the late 40s through the 50s through the early 60s to find Any insurance meeting, association meeting, whether it's Blue Cross, profits, for-profits, nonprofits, whatever, or any physicians meeting where they're not saying we've got to spread, they're not saying the insurance company model. I'm trying to help people understand what's going on, but these insurance benefits, even again, remember, physicians aren't so happy about working with insurers, but they realize that politically we have got to spread this, and their strategy works, and that they realize it's going to make it a lot harder for the government to intervene if they build up the market. And that's what happens. People get used to this model and this system, so that by the time we get to 1965, with the passage of Medicare and Medicaid, yes, you could have a Medicare program set up that's essentially managed through DC. Medicaid is, I think, again, a lot of your audience knows, those are state-based, even though they get federal funds. They looked very different. There's more standardization since the ACA, but those are state-run. But with Medicare, you get that because that's the private market just can't quite cover the senior citizens. They try desperately. They even go to the states and get special legislation passed to let them get out of antitrust rules so that they can combine their administrative capacity and their funding to try to cover senior citizens with insurance. But it's very limited insurance, just hospital benefits, pretty minimal. They're still losing money on it because they're senior citizens, and this is this pricey insurance company model that's driving up costs. So you get Medicare and Medicaid passed, and what you have reformers, the people and the policymakers writing the legislation, a lot of them are still some of the same players from back during the Truman time, right? Or they've been influenced or mentored by them. And they're like, I see the conversations where they're like, we wanted to displace this model, but it's too late. The market has already created this entire, huge institutional complex, and it's what consumers and voters are used to working with. We can make Medicare more palatable and sell it to the voter. One way is by saying, oh, it's the same. Your parents you're senior citizens, your parents will use the same system that you use. Go to their regular doctor, get it paid for. That's going to make it very politically popular. That way, the government officials in DC can harness the capacity that already exists in the market, because at this point, a massive complex of institutional connections and relationships have been created between the financiers, the insurers, and the providers, the hospitals and doctors. They have so many processes set up. 50s is when they start setting up more and more supervision, start looking over doctor shoulders more and more. And the government cannot, invent this A to Z by the time you get to the mid 60s. It would have been a different story if it was much earlier. They just don't have the organizational capacity. So that's why when you get to Medicare, you have the reformers saying, well, we don't want to use this model, but we have to. And kind of after the passage of Medicare, people just forget that there were other options on the table. And it's like, well, this is, just a natural thing that the system would naturally produce, without realizing how artificial it was and how much everybody recognized it and recognized the problems with the model before we get to Medicare and Medicaid. A lot of the reasons the insurers are able to start setting up supervision of doctors is because the political argument they're making. Doctors don't want to be supervised by the insurers, but whenever something erupts into the media that looks bad about insurance costs, or you don't usually have doctors doing a lot of like fraudulent things. They just behave according to incentives, I like to say, just like professors and journalists and everybody else. This is nothing. They're behaving like any of us would. But it does become just too tempting for some surgeons, especially because the fees are so high, that's where you get the most fraud. And of course, it's going to depend on the culture of the hospital and all, but you do have an unfortunate surgery crisis in the 1950s where people are just operating for easy fees. This starts to get discovered, but because it's bad publicity, this political argument has to be made. The AMA and the physicians they're going to now be dragged kicking and screaming to agree to some of the insurance company looking more over their shoulder, creating utilization review committees, your tissue committees and all the things you already have set up in hospitals and medical associations today were starting to be created in the 50s. And that's all going to be wrapped into Medicare, right? So you can see why policymakers like, we can't deal with paying the physicians and the hospitals and all that stuff. We've got to build on this model and basically have the insurance companies administer this program and be the go-between between us, the financial intermediaries, and the providers. So they just build on top of the insurance company model. So that's what happens there.
So it seems when I think about, what the AMA's goals were initially, it seemed like to me, they had 2 to 3 main goals. They wanted to keep physicians' wages as high as possible, and they wanted to prevent non-physicians supervising them, and then also wanted to not get sucked into bureaucracy. And in one sense, the AMA did not get what it wanted. Today, insurance companies effectively dictate how physicians can practice, whether the insurance is going to approve this drug or that drug. They have to go through this number of trials of these medications in order to go to this other medication. So it ends up being how physicians practice. And then also medicine now is so bureaucratized. But in one sense, the AMA, I think, ended up being fairly successful, which is that they managed to limit the supply of physicians and boost wages with their fee-for-service model. So do you feel like the AMA actually just ended up sacrificing all the stuff that they didn't want as much as the number one thing that they wanted, and they got that?
Yeah. And I would also argue too, that even though they initially, I mean, gosh, if you were practicing back in the 50s, you had it free and easy, like you're setting your own fees and stuff. So yeah, you really did have it free and easy for a very brief period of time, physicians. But I would still argue that they made a big mistake because financially, the insurers cut way into the payments that, I believe so much get cut off to that inefficiency of all the administration through insurers. So there's that argument to be made. The other thing is just the autonomy is the really big problem. Like you say, with medicine becoming standardized, losing the art. Oh, that condition doesn't even exist if the insurance companies haven't deemed it, given it a standardized treatment blueprint. That medicine might as well, or treatment or procedure doesn't even, if the insurers don't acknowledge it, it doesn't exist. That's part of my argument, is that they're now practicing medicine and shaping the practice of medicine the way physicians used to. So I would argue that I think the model they created, though, is very useful. It actually messes with distribution, because I do think it's useful for more marginal physicians, who would have more difficulty if everybody wants to live in an urban area. Younger, more inexperienced physicians would be forced, because they'd have to really just be in a marketplace, right? The AMA it wasn't just that they didn't want physicians or other people above them. It also just so offensive to them that physicians would compete against one another in a marketplace. So offensive, right? Even though we all know that, that's what we're doing when we're going and looking up our physicians and seeing their rating and all. But anyway, that was the whole thing of they're not part of the marketplace. So I would say that they didn't get that, right? They didn't get the autonomy and sovereignty that they wanted. And if they had gone with the prepaid group plan, I think they would have had all that. It just might be harder for some of the more physicians who practice on the margins to inflate their fees. So I think they're the ones who benefit more from this system, but other just kind of regular physicians, and especially ones who are top or very competitive, they wouldn't have had a problem anyway. It's just everybody wants to live near, I don't know, the good restaurants and the opera, and where all the other jobs are for family members and such. And so I think that's one reason we have physician distribution problems in inner city areas and in rural areas, is because the prices, the AMA set it up so that prices are more administered, and certain physicians can just, get by with that system, but they still limited the supply. We all know that there are areas in the United States that are way oversupplied with physicians and areas that aren't. And because the market isn't able to get in there and redistribute people, that's what happens.
One thing that's very clear is at each decision-making point, there's the path dependency of, okay, well, we already have all these insurance models in Medicare, so we're just going to keep going. We're just going to keep adding on to that. How do you think that the ACA fits into this healthcare landscape in terms of how it altered or entrenched what already existed before?
Sure. And that's a lot of American policies made that way, not just in healthcare. We have a propensity for creating these public-private programs that might be publicly funded, but use private organizations or businesses in order to provide benefits. And the ACA, again, there was a move by reformers who wanted to actually change the economic model on which the system ran. You can imagine the problems they were running up against, again, because, at this point, interests are so entrenched and voters are very scared of what are you guys going to change? How is that going to change what I'm used to? And so that made it very difficult politically. But the way that reformers with the ACA and the debates running up to it, 2008 to 2010, they were looking at a public option. And their hope was to offer a public option on the state exchanges to make it very generous with tons of benefits. But then because it would be provided by the government, preferably the federal government, they could just undercut all the, Blue Cross and private insurance for-profit company. Some Blue Crosses are for-profit, all their options in order to shrink the private sector on the vine. It's just that ACA did not work out even the way they thought. They were hoping to get a lot of people off of the employer provided into the state exchanges. And because employers, they don't want to hassle with this stuff at this point, the amount of time and money and they're having to deal with health insurance. And again, like I said, they would be paying, they decide who to hire and how to hire based on total cost, not based on your salary. So for them, it's just a lot of headache and you're foregoing a lot of income. So with the ACA, the idea was to get the public option through so that government officials could rearrange the system. But again, you can imagine why that was not popular. Yes, it was popular amongst academics and scholars and some journalists and policy officials, but it didn't have a chance of getting put into the final bill because you would have lost a lot of votes if that had gone through. If people couldn't tell their constituents, remember the famous line, you can keep your doctor. So it was clear what the public option was. So yes, the end, what is that? The punchline of that is then the ACA is built up top the insurance company model, right? You really lock it in for sure with Medicare. And by the time we come to ACA, you see how cemented and embedded it is there and how difficult it is to get around it. Actually, some of the more interesting ways of getting around it has been actually through the market and not through government reform policies, with things that physicians are coming up with of new ways to practice medicine and cut out the insurer and get away from a lot of these other models. But even in those cases, they have to often go to the state legislature to lobby to get old AMA supported laws from back in the 20s and 30s and 40s off the books, like against the corporate practice of medicine and stuff like that. So.
All right, we have two more questions for you. Let's say that you get to be in charge of all of healthcare in the US, or I guess there are two situations, one in which you're totally in charge and one in which you have a little bit of control. What do you feel like is the thing you could do, number one on your wish list if you're totally in control? And what do you feel like is the most realistic next step in making healthcare a more functioning system?
I would give more space to what providers are trying to do now. I think the physicians, I know how they want to practice and why they want to get out from under, for example, the insurance company telling them what they can do. And this movement we've seen to like direct primary care, of course, I want them to be multi-specialty, but then there's the whole issue with breaking into hospital admitting privileges and facilities, and that's a whole nother ball of wax. But I would like to see just more freedom in the market to move before everything was so roped into what you could do by state law. One issue, for example, is just that because health insurance is oddly regulated at the state level, long history for that, and not at the federal level, you've even in the past had things so complex that every health insurance policy had to look different by the state because people would just lobby the state legislature to make certain benefits, like say your chiropractors association would go down there and say, pass a law saying all the insurance offered here has to, include chiropractic care. And that sounds great, but you're not getting people the choice to be like, oh yeah, I definitely want that to pay for that. Or instead you're just increasing the cost of the policy. So I would love to see just more room for people to get out there and experiment, because I don't think that like there's one person who's like, oh, I have this great idea and this has to be the one model in area, because I think people have to get out there and figure out what people want. And I'm not an expert, but I do think if we had something like prepaid physician groups, which we're, like I said, I feel like we're seeing the nascent, first it was concierge care, and now it's more like Joe Six-Pack care, right? With some of these prepaid group models you have now. I'd like to give them more freedom, because if you imagine what the prepaid group models would have developed like, people like, for example, insurance companies, physician groups would have reinsured on the back end with insurance companies. Say you had a patient who reached $500,000 because you're the insurer, you're the group trying to figure out how to, or, $250,000 or whatever, then the insurance kicks in. But the insurer sees that with the incentives already lined up, they don't have to be in the medical exam room with you to the degree they are today, right? They are through these treatment blueprints, and you have to do this in order to get reimbursed. And then all these committees are going to come in and look at you. But if you had the incentive set up right, the insurance like, fine, yeah, I write you the policy. Once you have a patient hit this amount, whatever, we pay that. But it wouldn't be so much control and power. And then, of course, I think what would have happened, obviously, is as far as people being able to access care all around the country, whereas they have their one group near to where they live. I study a lot of different economic sectors, and for example, banking and the way different things work, like whether it's clearing houses or the way their correspondent relationships amongst different businesses and entities in other sectors, it would not have been a problem to have where you have a system of credits and stuff where people, if you're out of area, you just access someplace else. That wouldn't have been an issue. I think doctors would have had more power, would now today have the power over the hospitals instead of the flip, which at the beginning, in the first half of the 20th century, certainly doctors had more power than hospitals. Now that's flipped. I think physicians would be practicing medicine totally differently. There would be a lot more art and creativity involved in it. The problems that chronic patients have, or difficult to diagnose patients getting sent one to another. One thing I've made the point before is, you do everything you can according to what the insurance company will let you bill for. Then you send them to the next specialist. They keep getting sent specialist. Not only is it bad when they die in between specialists, but that information is lost. It doesn't get fed back into the system. That's valuable information that just escapes off into the ether that you guys need to know that you were treating this person, but nobody really owns the patient. So theoretically, their GP is managing all these please, we all know there is no way. The hours that GPs spend just managing paperwork, much less getting on the phone and managing all the specialists, especially their elderly patients, people are more complex. So that's what I think would have happened. And I think you would have seen such creative and imaginative things. You wouldn't have all these arguments over the division of labor. How the AMA is over in every state saying what nurse practitioners and nurses can and can't do because you guys want to be able to bill for that. Well, you wouldn't care about any of that. You would be like, my time is so valuable. The amount of years I spent in education and training. Yeah, I need to get in there, make the diagnosis, and then I'll have, heck, I'll pay somebody to just sit in there. They don't even have to be a nurse. You would figure out labor divisions so well, right, of how to do things. You would have, I nutrition classes for all your diabetic patients for free. If you're my patient, you would, a van to send around to pick up the elderly for their appointment. You would have to be creative because, that is the way. What you would be trying to do is please, the customers. And again, I just think the physicians would be so much happier because when they're incentivized correctly to practice this way and get to include the art, and then they can have those idiosyncratic things that they have with certain patients that, the standardized treatment blueprint that the insurer gives you today doesn't account for. Yeah, well, the model like that, you could see how if the government's involved, you give somebody a subsidy, go pick your practice, and there you go. So that would be my dream world.
And on that happy dream world note, we just want to thank you so much for coming on the External Medicine podcast. Before we close, is there anything that you wanted to mention or talk about that we didn't get a chance to ask you about?
Off the top of my head, I can't think of anything except, I guess, real briefly, since my discipline is history, and I know you've interviewed some economists, just to briefly mention what our methods are because they're so cool. And so your audience understands where I came up with this wild story. I didn't just come up with it. I was really surprised about some of the things my sources told me. So historians, we typically take longer to write articles and papers and stuff than a lot of other disciplines in the social sciences because our methods require us to look at primary sources, which are any kinds of documents or sources created by the people who are making the history. So I couldn't just go read a bunch of secondary, books, literature, scholarship already written about the American healthcare system. I looked at thousands, probably tens of thousands of documents of primary sources produced by the American Medical Association, Texas Medical Association, for all these different state medical associations. I interviewed physicians. I was in the archives of insurance companies, of Blue Cross, of Blue Shield, of different state ones, of the National Association. Actually, that was like a coup. I basically tracked down the son of the archivist of Blue Cross, but they had they used to have a big archive, but they had boxed everything up and put it in storage in the early 90s during budget cutbacks and institutional memory being what it is. They lost their collection. Nobody knows where it is. So I tracked down the son of the archivist who had like these boxes and boxes of these materials Xeroxed, and pulled them out of his shed and ran, teared up as I'm like, and the Kinko's like, I can't believe how great this stuff is, like board of trustee meetings and everything. I'm like, there was another time when I found the AMA documents, I also might have teared up a little bit too. But again, thousands of pages, boards of trustees meetings, inter-office memos, people going back and forth, arguing, letters, notes, lots of telegrams. I read so many JAMA, all the editorials, anything they were saying about politics for decades and decades and decades. So anyway, I'm just telling all that. That's how I was able to figure this out. And I can't even tell you, it's such a great way of doing things, because sometimes you would, from what you know from the scholarship, you'd be talking back to your sources saying, but you're not supposed to be worried about reform. Don't you know that President Eisenhower is in office and all the social scientists say that you didn't care and nobody cared about reform? You know what I'm saying? Like, the sources are telling you things that you don't expect, but and that can be hard, but if you just stick with it, that adds a lot of the interesting details when you follow down these rabbit trails. So that's why I just love my discipline so much. I love history. I adore our methods. I love being in the archives. So
once again, Christy Chapin's book is Ensuring America's Health, the Public Creation of the Corporate Healthcare System. We're going to have a link to your book in the show notes. Is there anywhere else on the internet where people can find out a little bit more about you?
I think just send them to I'm sure I have like a bio on my departmental website that's woefully out of date. So the book is great.
Excellent. Well, thank you once again so much for your time. This has been wonderful.
Oh, thanks so much, Mitch. I really appreciate it.